In this PowerPoint, we will finish up with the dimension areas 9 and 10, as well as look at the topics of clinical impressions and documentation in the assessment process. While dimensions 1 through 8 are used to obtain information on the client's life areas through the client's own perspective, dimensions 9 and 10 are used to reflect the clinical impressions the provider has of the client. Dimension 9 takes a look at motivation as well as the client's strengths and resources. In regards to motivation, this often involves reporting the stage of change, as discussed in Chapter 4, that the client seems to be in during the assessment. In addition, the provider may also determine the client's readiness to change. Both of these are based on the clinician's view of what the client has shared. Lastly, Dimension 9 also includes the provider's clinical impressions on the client's strengths and resources that can be used and incorporated into their treatment services. Next, looking at Dimension 10, this is the area that will reflect the provider's initial clinical diagnoses of the client. This is where you will include information on the client's diagnoses concerning substance use and addictive disorders per the DSM-5 criteria, and any other assessment tools used during the assessment appointment. In addition, any mental health and medical diagnoses reported will also be included. Lastly, you will include psychosocial stressors such as no recovery support, recent divorce, all of these which may impact the client's recovery process. In addition to the dimensions 9 and 10 listed in the book, there are other clinical impressions to include. One involves what is referred to as the client's mental status exam. While a full mental status exam can be lengthy and include a range of areas, a brief mental status exam is often included in the assessment process and follow-up appointments. This involves clinically assessing a range of areas related to how the client appears and presents during the assessment. We'll take a closer look at this in the next slide. The other area to include under clinical impressions is the follow-up service plan outlined by the provider. This indicates what recovery services are being recommended and why, and what has been agreed upon by the client. For example, a plan might be that the client is recommended to enroll in an outpatient service plan, or the client will begin residential treatment starting Monday. In addition, if follow-up or additional information is needed to complete the assessment, it would be noted here. Returning to the Brief Mental Status Exam, or Brief MSE, on this slide you will see an example of this type of form. The Brief MSE looks at a number of areas related to client appearance and presentation, and I will highlight a few covered on this form. The determination of a client's brief MSE should be clinically based, and the provider should pay strong attention to cultural and other factors to ensure that a fair clinical determination is made. The first area that is often covered is what is referred to as orientation. Generally, we look to see if a client is orientated to time, place, person, and purpose. This translates to 1. Does the client know the date, time, year? 2. Does the client know where they are? 3. Does the client know who he or she is? And 4. Does the client know the reason for this session? Along with orientation, a client's appearance is often noted. However, strong caution needs to be taken in this area, as a disheveled appearance can be very appropriate depending on the client's living situation and access to clean clothes in a bathroom. In these situations, a provider should not only mark the box that reflects the client's appearance, but include comments which reflect the appropriateness of appearance based on these additional factors. Turning to another area, a clinician doing a brief mental status exam will make sure a client sounds logical in their thoughts and speech, meaning they are making sense in their responses and their responses seem to match the questions we ask. Another area documented is if the client appeared engaged during the assessment. For example, did they seem interested in speaking with you, able to make eye contact as culturally appropriate, etc.? Or did they seem unengaged throughout the assessment? Again, as mentioned when discussing appearance, it is important to assess not just the presentation of the client, but the context as well to determine appropriate presentation. If a client is especially anxious throughout the assessment, this may be very appropriate based on the client's perception of the importance of the assessment. Likewise, if the client is slow in speech or showing a depressed mood when talking about significant trauma in their life, this would be viewed as a very appropriate presentation. In these situations, it is important to add additional comments in the comment box to reflect the provider's awareness of these factors. The last area to cover in this PowerPoint is documentation. When discussing the topic of assessment, it is important to look at the actual process of writing and documenting the information contained in an assessment. As mentioned, generally an assessment is reflecting two things. One, the client's view and perspective on key life areas, and two, the provider's clinical impressions. When documenting each of these areas, it's important to use what is called a recovery-oriented documentation style. This style focuses on creating a strengths-based document which promotes honest and respectful clinical communication. Part of this style is reflected in the use of the word client or consumer versus patient. Likewise, many documents will use person or the first name/initial to promote a more respectful approach. These types of word selections continue to evolve in a way that fosters more respect towards those seeking services. In addition, this style also means that the information included in the assessment is accurate, collaboratively done with the client, and helps to foster an empowering pathway to recovery. As noted on this slide, key elements of recovery-oriented documentation incorporate the client's own perspective, using their own phrasing and quotes in the assessment, avoiding language that stigmatizes or demeans, avoiding phrasing that suggests interpretations, assumptions, or judgments, as opposed to solid clinical determinations, and reducing jargon that uses abbreviations or wording that would only be understood by clinical staff. So, to accurately reflect both the information obtained in the assessment in a recovery-oriented and professional manner, we look to use specific phrasing and wording for the dimension areas. For dimensions 1 through 8, which reflect the client's view of their life areas, we use phrasing such as client stated, client reported, client mentioned, client explained. For example, client stated use of alcohol started at age 10. She or he reported a long family history of substance use. This ensures that the information is being presented from the client's view and reduces the potential for the provider to show any bias or judgment in these areas. For clinical impressions, the wording and phrasing to use is as follows: client seemed, appeared, demonstrated, etc., rather than saying client is, client was. The reason for this is because you want to make sure it comes across as your own clinical impressions based on the information you obtained at the screening. Writing clinical impressions in this manner works to support recovery-oriented documentation, as it makes it clear that these are professional reflections of the provider at that time versus a judgment or label being attached to the client. So an example in this area would be, client seemed engaged during the session and showed motivation to start treatment services. She or he showed behavior consistent with the action stage of client readiness. When completing assessments, it is valuable to keep in mind ways to foster more recovery-oriented documentation both in the client-reported areas and clinical impressions. This now completes our discussion of assessment and the assessment process.